Hello, Bitoy. Nagsisimpa ko ng dami. Okay lang ba? Nagsisimpa?
Yes po, Doc. Naririnig po.
Okay na, nakikita.
Yes po, Doc.
Wait lang ah. Okay. Nakikita din yung ano,
Yes po,
presenter.
Doc. Yes po, nakikita po yung presenter. Pero
Paano
nag-slide show
tanggalin
po
yun?
kayo. Doc,
Ha?
yung kanina po ginawa nyo, nag-slide show.
Ano yun?
Yung ginawa nyo before that one, naka-full screen po siya na slideshow.
So, hindi ko nakikita.
pinapanood ako sa slideshow.
Pero paano yun pag presenters yun na sa akin? Hindi ko magawin yun.
Sabi po ng classmate namin, try niyo po sa display settings, tapos swap to present review.
Display settings saan? Sa home? And then,
Try niyo po yung show present review. Baka
okay yung swap?
yes po.
Ayun naman.
But if ayaw pa po, I think pinapakita po talaga ni Zoom lahat ng yung buong screen niyo po.
Okay. Sige na, start na tayo. Okay, we should start na. So good morning. For today's activity, we will tackle 2 topics. So the first one is the gestational trophoblastic disease or hydatidiform mold, and gestational trophoblastic neoplasia, and obstetric hemorrhage. Okay. So for our first part, we will discuss hydatidiform mold and your gestational trophoblastic neoplasia, or also known as your GTN. So in hydatidiform mold, we shall tackle the complete versus partial mold, the clinical features of hydatidiform mold, the diagnosis, management, and cost of follow-up. In the gestational trophoblastic neoplasia, we will also tackle the clinical features, your stages, how would you diagnose your GTN, the management, and the post follow-up. So we have index case, a 35-year-old gravid 3, gravid 5 para 3, 3013, who came in due to profuse vaginal bleeding and passage of vesicular tissues. She was admitted at 9 weeks age of gestation. So for the pertinent findings, the patient is conscious, coherent, tachycardic, with a BP of 80/60, cardiac rate of 112, R around 26, noticeable pallor. On internal examination, the cervix was open, the corpus was enlarged to 16 to 18 week size with minimal vaginal bleeding. Transvaginal ultrasound reveals an endometrial cavity containing a heterogeneous mass measuring 9 by 6 by 4 centimeters with multiple cystic spaces. The baseline beta Hcg was 1.4 million and the hemoglobin was 48. Other laboratories done were as follows. The thyroid profile, the FT4 was increased, the TSH was decreased, and the rest were unremarkable. So what is gestational trophoblastic disease? This is a general term used for a group of diseases with abnormal proliferations of your trophoblast. This includes your hydatidiform mold and your gestational trophoblastic neoplasia. So what is hydatidiform mold? Hydatidiform mole is an abnormal conception with excessive placental and little or no fetal development. They grossly resemble a bunch of grapes with or without fetal components. We have two types, your complete hydatidiform mole and your partial hydatidiform mole. So how this happened? For the first part, the complete hydatidiform mole, they have normal chromosomal number. However, they are androgenic. That is, all the 46 chromosomes in the molar tissues are paternally derived. Majority of your complete hydatidiform moles arise from the fertilization of an empty ovum. So this one, fertilization of your empty ovum by a haploid sperm that is 23X that duplicates itself to restore the 46XX karyotype, and they are called as diandric diploidy. Another process, so you see, a 46YY karyotype is not known to thrive beyond a few cell embryo. Hence, the excessive paternal and the absence of your maternal genomes results in your exuberant trophoblastic growth without the development of your fetal components. So meaning to say, the paternal genomes, they are the one that responsible that causes these excessive these vesicular tissues. Another formation is your diandric dispermy. This is the fertilization of an empty ovum with a two haploid sperm, resulting in diandric dispermy. Next is your partial mole. So this is the gross picture of your partial hydatidiform mole. There are focal areas of vesicular tissues. So if you could see the arrows, there are vesicular tissues interspersed within the normal-looking placenta. Partial hydatidiform mole are generally triploid with the abnormal conceptus resulting from the fertilization of a normal haploid ovum by two haploid sperm. This one. So normal, in partial hydatidiform mole, the ovum is not empty. It is normally with haploid genome and fertilized by two haploid sperm, resulting in triploid partial mole 69XXX, 69XXY, or 69XYY, which is, however, very rare. So the presence of your maternal genome allows the fetal development. However, it is genetically abnormal. And the presence of your paternal genes results in the trophoblastic overgrowth. For the incidence, the reported worldwide incidence of your hydatidiform mole is 1 to 2 per 1,000 pregnancies. However, Southeast Asian remains to be 7 to 10 times higher than in Europe or your North America. Among the Southeast Asian countries, Indonesia has one of the highest reported incidence rate with 1 in 77 pregnancies. So the national prevalence rate is 2.4 per 1,000 pregnancies and 14,000 per 1,000 pregnancies in UPPGH admission in the year 2002 to 2008. So what are the risk factors of your hydatidiform mole? These are the maternal age, the paternal age, your reproductive and obstetric history, racial factors, and your diet and nutrition. So for the maternal age, this follows a J-curve pattern, which is an increased risk of ages less than 20 years and greater than 40 years old. Going back to the pathophysiology of your hydatidiform mole, most commonly in your complete hydatidiform mole, the defect end there is your ovum. That is why The maternal age is usually a risk factors in having a hydatidiform mole, because in very young age and in the extremes of ages, the ovum is not yet, can either be immature pa din, or in the extremes of age, the ovum is not has not good in quality. For the paternal age, greater than 45 years old is associated in complete mole but not on partial mole. For the reproductive and obstetric history of previous hydatidiform mole, nulliparous women with history of miscarriage or twin pregnancy and artificial insemination has increased risk of having a hydatidiform mole. For the racial factors, we mentioned a while ago that in the first world countries, hydatidiform mole is very rare. And however, it is increased in the third world countries, and the Philippines is included in the third world countries. Diet and nutrition associated with decreased dietary carotene and animal fat. So what are the clinical presentations of your molar pregnancy? Usually, the patients came in, of course, amenorrhea, positive pregnancy test, vaginal bleeding, and passage of vesicular tissues from the vagina or excessive uterine enlargement. So going back to the index case, the patient came in at the emergency room due to vaginal bleeding and passage of your vesicular tissues. And on internal examination, the patient has a 16 to 18 weeks age of gestation, size of the uterus. However, the patient is only on her 9th week's age of gestation. So for the medical complications, hydatidiform mole is associated with anemia, preeclampsia, hyperthyroidism, electrolyte imbalance, hyperemesis gravidarum, pulmonary insufficiency, and disseminated intravascular coagulopathy. However, it is rare. Going back again to our index case. So the patient, medical complications of the patient has anemia that is due to your vaginal bleeding. For how long, we do not know. And again, on the profile of the patient has elevated FT4 and decreased thyroid stimulating hormones. So meaning to say the patient has hyperthyroidism, or we call it thyrotoxicosis secondary to your gestational trophoblastic disease. Electrolyte imbalance or hyperemesis gravidarum, that so electrolyte imbalance could be secondary to your hyperemesis gravidarum. So why is it that patients with H mole or hydatidiform mole or experience severe hyperemesis or experience severe vomiting? That is because due to your elevated beta Hcg. So medical complications could also your pulmonary insufficiencies, that is due to your vesicular tissues. So the sago-saguan, hindi siya mag-throw, mag-emboli. And as I said, disseminated DIC, rare but it could happen. So what are the diagnostic tests that we request for patients we suspect for hydatidiform mole? So most common is your pelvic ultrasound. This is the most accurate non-invasive imaging modality for your hydatidiform mole. So for the complete hydatidiform mole, the typical snowstorm pattern, which is a complex echogenic intrauterine mass containing many small cystic spaces. Or they describe it as an honeycomb appearance. For the partial hydatidiform mole, this may reveal fetus or abnormal gestational sac along with the focal cystic spaces with the hydropic placenta. So if you could see, this is an example of a picture of partial hydatidiform mole. There is a fetus in there and a hydropic placenta with focal cystic spaces. Compared with your complete hydatidiform mole, No fetus, completely cystic spaces. There are multiple cystic spaces. Aside from that, if the patient has funds or if the beta Hcg is available in the hospital, you could request for that one for your serum beta Hcg. Aside from that, we will request also for your chest x-ray. Why? Because as I said a while ago, one of the complications of your high DATD4 mole is pulmonary insufficiency. Aside from that, maybe we could have an idea if upon admission, the high DATD4 mole or the gestational trophoblastic disease is already gestational trophoblastic neoplasia, or there's already a metastasis to the lungs. Other diagnostic tests you would request are your CBC with your differential and your platelet count, your blood type. So why is this so? Because going back to the medical complications, the patient's medical complication is having an anemia. So we request this one to be able to prepare blood if necessary. Liver function test, renal function test, urinalysis. So, and aside from that, I forgot the serum electrolytes. Why do we request for that one? Because aside from the medical complications, we are preparing the patients if they are able to receive the chemo prophylaxis. So thyroid function test is being requested also, and if there is an elevated beta Hcg, automatic the patient has a thyrotoxicosis or hyperthyroidism that is secondary to your GTD. Cytogenic and molecular biological examination when the diagnosis of IDATD formal is in doubt. However, this is being requested only for academic purposes. So how would you differentiate your complete versus your HIDA-TD4 mole, your partial HIDA-TD4 mole? We have these features. So the most common differentiation is your karyotype. As we have said, the complete HIDA-TD4 mole, they have a normal genomes that is 46XX or 46XY. However, in your partial HIDA-TD4 mole, they are triploid genome 69XXX or 69XXY. Apart from that, so the fetus or the embryo is absent in your complete HIDA-TD4 mole, however present in your partial HIDA-TD4 mole. The villus stromal apoptosis is prominent in your complete HIDA-TD4 mole, however limited in your partial. The villus outline and edema, they are round and diffused in your complete, however is scallop and focal in your partial HIDA-TD4 mole. Trophoblastic proliferation is marked, however minimal and focal in your partial. So P57 KIP2 immunostaining is negative for complete HIDA-TD4 mole, and your partial HIDA-TD4 mole is positive. So what is the P57 KIP2 immunostaining? So it is being used if in the laboratory, if there is a problem in signing out if it is complete or partial HIDA-TD4 mole. P57 KIP2, they are paternally derived but maternally expressed. So going back again to the pathophysiology of your fertilization of or formation of your complete HIDA-TD4 mole, we say that in complete mole, it is paternal chromosome. However, in your partial mole, there is a maternal chromosome that is being involved. So that is why negative in complete HIDA-TD4 mole and positive in partial mole. Because as we have said, P57 KIP2, they are paternally derived but maternally expressed. for the diagnosis, molar gestation, for the diagnosis of your complete mole, we call it hydatidiform mole or molar gestation. However, in partial hydatidiform mole, we could also associate it with missed abortion. So that is why if the patient undergone, for example, curettage, it is being required also to send a specimen for histopath, because not all abortion are all normal abortion. Sometimes it could be a partial hydatidiform mole that is being misdiagnosed as missed abortion only. For the uterine size, the complete hydatidiform mole is large for dates, and partial hydatidiform mole, they are small for dates or at par with the age. Thecal luteincies, usually they are 20 to 30% present in your complete hydatidiform mole, however rare in your partial mole. Medical complications, frequent in your complete hydatidiform mole, however rare in your partial hydatidiform mole. And post-molar malignant sequelae is 15 to 20% increase in complete hydatidiform mole, however 4 to 6% in your partial hydatidiform mole. That is why, to reiterate, all the abortions, the specimen for abortion should be submitted for histopath, because the missed abortion could be partial H mole, and if we see this one, there is a 4 to 6% post-molar malignant sequelae of your partial hydatidiform mole. So for the ultrasound, we have this snowstorm pattern or honeycomb appearance in your complete hydatidiform mole. For partial, there is a fetus within a placenta with cystic spaces. So this hydropic abortion is a non-molar placenta. This is just a normal abortion. For the serial beta Hcg, markedly elevated, all are markedly elevated except for your abortion, elevated but on decline. For the karyotyping, diandric diploidy for complete mole, for partial hydatidiform mole, it is triploid, as well as in your normal abortion. Why? Because what is the most common cause of your abortion? It's still the chromosomal problem. So for partial anisotropic abortion, they have a positive result, and negative for complete mole. So it is paternally derived but maternally expressed. In a normal abortion, still maternal genes is still present together with your partial hydatidiform mole. So how would you manage your hydatidiform mole? So first, you have to recognize the medical complications. So that is why we have your laboratory test. So first is the correction, recognition, and the treatment of the medical complications. Do not go yet with the how would you evacuate your molar pregnancy. First, you have to recognize and treat the medical complications. When the medical complications were treated, then you will do your molar evacuation. So there are two types of how would you evacuate your molar pregnancy. This could be either your suction curettage or your hysterectomy with mole in situ. So suction curettage is preferred method of molar evacuation regardless of the uterine size, regardless of the age of the patient. So this is the preferred method. However, hysterectomy with mole in situ is for patients who have completed their desired family size. Because our goal is in the future, the patient will not conceive, because there's a possibility of another molar pregnancy, or again, the sequelae, we all know that it could lead to gestational trophoblastic neoplasia. That is to decrease the tumor load. said again, the thick lutein cyst is present in your complete hydatidiform mole. But then, they are best left alone because thick lutein cysts will regress spontaneously within 8 to 12 weeks post-evacuation. Hysterotomy and the use of oxytocin or prostaglandins to effect spontaneous smaller expulsion are associated with incomplete evacuation, significant hemorrhage, and higher incidence of post-molar gestational trophoblastic disease. So what we do if the patient came in with a closed cervix, we do not give your oxytocin or your prostaglandins, such as your cervical ripener, such as your evening primrose, but then we recommend to give the patient the laminaria or catheter, intracervical catheter, instead of giving your oxytocins and your prostaglandins. Aside from that, in giving that, you are putting the patient in high risk of having a pulmonary embolism. So how would you do your suction curettage? So appropriately type and cross-match blood should be available before molar evacuation. Oxytocin infusion is administered only at the start of your curettage if you are ready in doing your curettage and not prior to doing your curettage. A side drip of 10 units of oxytocin in 1 liter of your lactated ringer solution. So the patient is in semi-Fowler's dorsolitotomy position, especially when the uterus is greater than 14 weeks age of gestation. Mechanical cervical dilatation is done if the cervix is unyielding. Or preoperatively, as I said a while ago, laminaria 10 can be used without risking the patient to tumor embolization. Appropriately type and cross okay. During suctioning, a 12mm cannula is generally sufficient to allow evacuation of your molar products. The surgeon's other hand should be positioned on the uterine fundus to continuously assess the uterine size and the tone. The caution and the routine use of hysterometer for pre- and post-uterine depth, as it can lead to uterine perforation. To ensure complete removal of your chorionic tissues, sharp curettage follows suction curettage. Tissues obtained through suction curettage are submitted separately from the tissues obtained by your sharp curettage. So this is an example of your laminaria. And this is your cannula, 12mm cannula that is being hooked to your suction machine. That is the one that sucks the vesicular tissues. So it is chemo prophylaxis. It is a randomized trials that have shown the use of chemo prophylaxis at the time of evacuation of high-risk complete hydatidiform mole significantly decreases the development of your gestational trophoblastic neoplasia from approximately 50% to 10 to 15%. However, you should tell your patient that they are not being spared from having a gestational trophoblastic neoplasia or tumor even if they are given your chemoprophylaxis. It will just decrease the development of your GTN. However, there is still a possibility, a 10 to 15% possibility of having a gestational trophoblastic tumor. So what is the drug being used for the chemoprophylaxis? That is your methotrexate. And in some other countries, they make use of your actinomycin. However, in the Philippines, we make use of the methotrexate. Why? Because aside from it is cost-effective, this can be given even as an outpatient basis. So the mechanism of action of your methotrexate, it inhibits dihydrofolate reductase thereby inhibiting your purine nucleic acid synthesis and cellular replication. The dosing is 0.3 milligram per kilogram per day. It is being given for 5 days and only one course is being given for chemoprophylaxis. For actinomycin D, it intercalates between base pairs which causes inhibition of your DNA-dependent RNA synthesis. 500 micrograms single dose is being given. So, identifications of women at risk for your malignant degeneration who may benefit from the prophylactic chemoprophylaxis. Patients with advanced maternal age, that is, patients 40 years of age and above, uterine size larger than gestation by 6 weeks, serum beta Hcg titer of greater than 100,000, the size of the thecal luteincies is greater than 6 centimeters, a recurrent height at 84 mole, documented height at 84 mole with normal twin, and the presence of any medical complications associated with an increased trophoblastic proliferation. And for the number 8, poor patient compliance to follow up. So if you know that the patient lives in the very far away areas, you might give your chemoprophylaxis because for sure the patient will no longer follow up. So if there are benefits in the prophylactic chemoprophylaxis, we should also take note for the contraindications on when not to give to your patients. That is, if the hemoglobin is less than 100, WBC of less than 3, ANC of less than 1.5, platelet count of less than 100, if there is any active infection, and the presence of your liver and renal dysfunction. So, chemoprophylaxis does not eliminate the need for close follow-up after molar evacuation. So, there is still a need for a close follow-up even if the patient receive your chemoprophylaxis. So, it depends on the physician, on the attending physician if he or she will give or not to give your chemoprophylaxis. So, how would you follow up your patients? The schedule of your serum beta Hcg is as follows. 1 week after your molar evacuation and bi-weekly or every 2 weeks until normal. So 5 milli-international units and below is the non-pregnant normal beta Hcg. So if you already have a bi-weekly normal beta Hcg result, then you could ask beta Hcg once a month for 6 months. And advise the patient to not conceive within 6 months. More than half of the patients will have a complete regression of Hcg to normal within 2 months of your evacuation or 8 weeks post-evacuation. So, nag-normalize naman na sila. And going back again, that is why the thecal luteincies also regresses within 8 to 12 weeks. So, if there is an elevated beta Hcg, thecal luteincies is still present. And if the beta Hcg normalizes, thecal luteincies will also regress. So, within 2 months or 8 weeks. So, when do you refer to the trophoblastic specialist? If the beta Hcg is more than high levels of beta Hcg more than 4 weeks post-evacuation, and if there are 2 consecutive rise in beta Hcg during the weekly determination, and through 3 consecutive plateauing, that is 10% decline at any time after evacuation. So what you should remember is one is 2 rise, 3 plates, 2 rise, and 3 plateaus. And a clinical or histologic evidence of your choriocarcinoma or any metastasis at any site. So going back again for our index case, the final diagnosis is hydatidiform mode, anemia secondary to acute blood loss corrected, thyrotoxicosis secondary to GTD, resolving, status post-suction curettage, and status post-methotrexate chemoprophylaxis. So, as I said a while ago, suction curettage is the best method that we could offer, especially if the patient came in with profuse vaginal bleeding. However, if the patient is non-desirous of pregnancy and has a stable vital signs, you could offer a hysterectomy mol in situ in our index case. So, if what would you give to the patient as a contraceptive? So, a low-dose combined oral contraceptive pill is the preferred method of your artificial contraception because they have the advantage of suppressing your endogenous luteinizing hormones, which may interfere with the measurement of your Hcg at your low levels. So for young patients with intact uterus, pregnancy may be allowed after 6 months of your normal serum beta Hcg levels. So when the patient gets pregnant, antenatally, you would ask a beta Hcg at 20 weeks and 32 weeks, and postpartum at 6 weeks and your 10 weeks. All placenta in subsequent pregnancy should be submitted for histologic examination. For every succeeding pregnancy, an early ultrasound should be performed because of the risk of another molar pregnancy. So this is the risk of another pregnancy if the patient one molar pregnancy, 1 to 2% of another risk of molar pregnancy. Recurrent molar pregnancy, the risk of another pregnancy of molar pregnancy is 15 to 20%. So we've done with your benign GTD or high density mole. So before we proceed with your GTN, your gestational trophoblastic neoplasia, do you have any questions?
No questions for me.
Come again?
No questions for me.
No questions. Okay, we proceed to your GTN. We have another topic pa pala. So your gestational trophoblastic neoplasia is the malignant end of the gestational trophoblastic disease spectrum. There are 4 clinopathological conditions that make up this entity. Your invasive mole, that is, it follows a complete mole or partial hydatidiform mole. Your choriocarcinoma, the placental site trophoblastic tumor, and your ETT or your epithelioid trophoblastic tumor. So for the clinical terms, we have the persistent trophoblastic disease, your GTN. So your persistent trophoblastic disease is not presently being used, and these definitions falls under the gestational trophoblastic neoplasia. So dati, they call it as persistent trophoblastic disease. However, now the term is being used is gestational trophoblastic neoplasia. A clinical term that denotes a disease state in which there is physical, biochemical, and radiologic evidence of invasive mole, choriocarcinoma, placental site trophoblastic tumor, and your epithelioid trophoblastic tumor. So for the invasive mole, this is a tumor or tumor-like process invading the myometrium. That is why it is called as invasive. So there is an invasion of the myometrium and characterized by trophoblastic hyperplasia and persistence of placental villus structure. So choriocarcinoma, an epithelial malignancy of trophoblastic cells formed by abnormal proliferation of cytotrophoblasts and syncytiotrophoblasts in the absence of your chorionic villi. So the next two are very, very rare kind of your GTN, the placental Cytoplastic tumor, a rare neoplastic proliferation of intermediate trophoblast that invade the myometrium at the placental site after pregnancy. However, for the epithelial trophoblastic tumor, it is also rare, which is the malignant counterpart of the intermediate trophoblast of your chorionic leaf. So we have here again an index case. A 34-year-old gravidate para 6026, status post stamol in situ. She has a chief complaint of hemoptysis or coughing out of blood. 5 months after operation, she was admitted at the tertiary government hospital, and she was diagnosed as PTB and started with anticox. So chest x-ray was done, and this revealed multiple nodular opacities of varying sizes seen through both lung fields, particularly in the lower lobe. So if you could see, usually the term for this one is the cannonball appearance. This one at the lower lobe. And the beta Hcg monitoring here as follows. So there is an increasing beta Hcg. From July 25, the beta Hcg was 1,721, and after 2 weeks, it increased to 69,614. So for the clinical presentation of your gestational trophoblastic tumor or neoplasia, again, vaginal bleeding is the most common presenting part. And there is an anemia, uterine enlargement, acute abdomen secondary to your tumor perforation, or if there is an invasive mode, tumor rupture, I should say. If there is an infection, and the signs and symptoms pertaining to the site of metastasis, such as there is a vaginal mass, pulmonary insufficiency, or the tumor bleed. Like in our patient, the patient complained of hemoptysis. In some, CVA or cerebrovascular accident, ruptured viscous, hepatic bleed, and intraperitoneal bleed could also be a presenting signs and symptoms of your GTN and lateralizing neurologic manifestations. Again, how would you diagnose for your GTN? Aside from the increasing increasing beta Hcg, you could also ask for your diagnostic test. Again, the pelvic ultrasound. Okay, there will be your ultrasound or specifically your transvaginal sonogram is helpful in the diagnosis and monitoring response to treatment following chemotherapy. A color flow Doppler can define regions of increased vascularity, representative of invasive disease, and enhanced uterine perfusion, distinct from the seen in the conditions related to pregnancy or abortion. Usually, our sonologist would report if there is a positive for color flow Doppler. So aside from your transvaginal ultrasound, again, you should ask for your blood typing, your liver profile, renal function test, serum electrolytes, urinalysis. And aside from that, we will request for your whole abdominal ultrasound, your chest x-ray again, and for your organ-specific CT scan or MRI. So, this is the laboratory test. The term for laboratory test in patients diagnosed with GTN is your metastatic workup. So why do we need for the whole abdominal ultrasound? That is to make sure that there are no distant metastases, such as metastasis to the liver, to the spleen, kidneys, intestines, and the like. So again, also for the chest x-ray, So to rule out lung metastasis. However, if the chest X-ray is normal, ideally in a good hospital setting, a chest CT scan with contrast is being asked when the baseline chest X-ray is normal. And if in the chest X-ray, there are at least 3 centimeters in diameter, we should request for a cranial CT scan with contrast in neurologically asymptomatic patients with chest radiograph demonstrated a lesion of at least 3 centimeters in diameter in a normal chest X-ray, regular chest X-ray. Because 3 centimeters in diameter size of the lung tumor, there is an increased risk that there will be a brain metastasis later on. So how do we stage for your gestational trophoblastic tumor? We make use of your combined FIGO anatomic staging and WHO prognostic scoring system of 2000. So the FIGO anatomic staging, this is a system that defines the extent of the disease. However, your WHO prognostic scoring system predicts the possible resistance of the tumor to single-agent chemotherapy. So for the stage 1, it is confined to the uterus. Stage 2 extends outside the uterus but still confines to the pelvis. Stage 3, pulmonary metastasis. And stage 4, metastasis to the other side, such as in the brain, the liver, kidneys, intestines, spleen, and the like. So how do we do the prognostic scoring? The factors are your age, the antecedent pregnancy, the pregnancy interval, or how many months that this happened, your beta Hcg result, the largest tumor size, and other sites of your metastasis, number of metastases, and prior chemotherapy, or if the patient received a chemo prophylaxis prior to that. So the low risk is 0 to 6, and high risk if the patient is scored 3. So they are scoring. Unlike other cancers, treatments can be started without histopathologic confirmation of the disease. And the treatment of your gestational trophoblastic neoplasia is multidisciplinary. It should be carried out in centers with trained specialists for trophoblastic diseases, because the overall morbidity in trophoblastic centers are less than the mortality in general hospitals. So the mainstay in the management of your gestational trophoblastic neoplasia is still your chemotherapy. Chemotherapy pa din. Surgery and irradiation, they are adjunctive. That is to help your chemotherapy. But the chemotherapy is the mainstay in the management of the GTM. So for your chemotherapy, for stage 1, they are known as the non-metastatic disease. So for the stage 1, regardless if it is stage 1 and risk score of 11, 12, 13, 14, 15, still the management is a single-agent chemotherapy, either methotrexate or actinomycin. And the consolidation courses being given is 2. For the stage 2 to 3 low risk, that is WHO less than 7, or okay, let's say stage 2 to 3, risk score of 6, still single agent. So huwag kayong malilito. Do not be confused. If the stage 1, if the stage is 1, and the risk score is 9, 10, still single agent, because stage 1 that is confined in the uterus only, it is a non-metastatic disease. However, if it is stage 2 to 3 low risk or less than, prognostic score less than 7, single agent, still single agent. However, if it is a stage 2 or 3 high risk, that meaning greater than 6, we make use of your multiple agent chemotherapy in the form of your IMACO. And we make use of 3 consolidation courses. Stage 4 automatic, IMACO. So, chemotherapy for resistant diseases, we have the term salvage chemotherapy. So, it's nice to know lang ito. So, chemotherapy is shifted to another regimen if toxicity or drug resistance develops. And what is the meaning of the consolidation or the cleanup course? Additional chemotherapeutic courses given after the first normal beta Hcg titer. So, contraindication in giving your chemotherapy, hemoglobin of less than 100, WBC of less than 3, platelet count of less than 100, severe renal or linear dysfunction, and any active infection. So, these are the terms only for the responses to treatment: adequate response, partial plateauing, biochemical remissions, and resistance. So, adjunctive treatments, as I said a while ago, surgery and irradiation, these are only an adjunctive treatment indicated for appropriately selected patients at any age of the disease, and it reduces the tumor load, resulting to a decrease in the number of your chemotherapeutic course. So, what are these adjunctive surgery? It could be your hysterectomy, resection of the uterine fundus, oversewing of the actively bleeding vaginal lesions, thoracotomy, or craniotomy. And radiation therapy, we make use of 3,000 to 4,000 centigrade divided in 20 fractions for patients with brain metastasis. So how would you follow up for the GTN patients? So for the low risk, 2 consolidation courses, and for the high risk patients, 3 consolidation courses. And after your chemotherapy, monthly beta Hcg monitoring for the first 6 months, every 2 months for the next 6 months for first year, every 3 months for the second year of follow-up, and for the rest of her life, every 6 months. And clinical examinations should be performed during each follow-up. Annual chest x-ray is being requested, and then if the uterus is still intact, every 6 months. And the patient is advised to avoid pregnancy during the first 1 year, not 2 years, first 1 year following the biochemical remission. A safe and effective form of contraception is the preferable low-dose OCP is still preferred. So for the treatment of the 2 rare types, that is your PSTT or your ETT, they are not responsive to chemotherapy. That is why the primary treatment is still the surgery. So this is the last part. For the GTN, we do not need histopath result before we can start your chemotherapy, because the beta Hcg is a sensitive tumor marker for monitoring. Almost always 100% cure rate if early detected and properly scored based on FIGO and WHO scoring. Chemotherapy is the primary mode of treatment, And if there's a high index of suspicion of vaginal mass, please do not do biopsy. So, what are the IMACO pala? IMACO is composed of your etoposide, methotrexate, actinomycin, cyclophosphamide, oncovir, or known as your vincristine. And this is the last part. Any questions with regards to your GTN?
I think there's no question.
Ano yan? Come again?
I think there's no question from that.
So there is a question in here. Now, what will be the cause of the empty ovum seen in the computed hormone? Because it's defective. Either it could be immature or the quality of the egg is not good anymore because of the advancing maternal age. Still the quality of the ovum that causes being empty or is being defective. If there are no other questions, should we proceed to another topic? Para wala nang utang sa inyo.
Yes, po.
30 minutes lang, mabilis lang yun. So our next topic is obstetric hemorrhage. So for our outline of the topic, the causes of your obstetric hemorrhage, your uterine anatomy, uterine inversion, injuries to the birth canal, purporal hematomas, rupture of the uterus, abruption of placenta, placenta previa, and placenta accreta syndrome. So obstetric is a bloody business. So the mechanisms of normal hemostasis after delivery is this one. The amount of blood flow through your spiral arteries near term is at least 600 ml per minute. These vessels have no muscular layer because of their endotrophic remodeling, which creates a low pressure system. With placental separation, these vessels at the implantation site are avulsed, and hemostasis is achieved by myometral contractions, which compresses these relatively large vessels. Importantly, an intact coagulation system is not necessary for postpartum hemostasis unless there are lacerations in the uterus, your birth canal, or the perineum. So traditionally, the definition of postpartum hemorrhage is loss of 500 ml of blood or more than after completion of the third stage of labor, or greater than 1,000 ml after cesarean delivery. A normal pregnant woman tolerates blood loss at delivery that approaches the volume of blood that she added during pregnancy. Whenever the postpartum hematocrit is lower than one obtained on admission for delivery, a blood loss can be estimated as this one. So you have to calculate the pregnancy added volume plus 500 ml per 3 volume percent decrease of the hematocrit. So these are the causes or predisposing factors of vulnerable patients: your abnormal placentation, injuries to the birth canal, obstetrical factors, and your vulnerable patients, including your so. You your uterine anatomy. So for the abnormal presentation, we have your previa, abruptio placenta, placenta accreta, ectopic pregnancy identity for mole. Injuries to the birth canals if there are episiotomy and lacerations, forceps or vacuum delivery, cesarean delivery. For obstetrical factors, obesity, previous postpartum hemorrhage, early preterm pregnancy, sepsis syndrome. And for your vulnerable patients, or patients with comorbidities such as patients of preeclampsia or eclampsia, chronic renal insufficiency, and they have a small stature. And your uterine anatomy. So the timing of hemorrhage, usually antepartum hemorrhage, the bleeding during pregnancy, second or the third pregnancy. You have always rule out the possibility of a bloody show, especially for slight bleeding. What are the causes of antepartum hemorrhage? It could be your placenta previa, abruptio placenta, vasa previa, or your uterine rupture. Any pregnancy with antepartum bleeding remains at risk for an adverse outcome even though bleeding has stopped and placenta previa has been excluded sonographically. So for the postpartum hemorrhage, frequent causes are your uterine anatomy with bleeding from the placental implantation site, genital tract trauma, or both. Initial assessment should attempt to differentiate uterine anatomy from the genital tract lacerations. Persistent bleeding despite a firm, well-contracted uterus suggests that hemorrhage most likely is from your lacerations. To confirm that lacerations are source of bleeding, careful inspection of the vagina, cervix, and the uterus is essential. So for the late postpartum hemorrhage, that is bleeding after your first 24 hours. What are the causes of your obstetrical hemorrhage? Okay, uterine atony. This is the most frequent cause of your obstetrical hemorrhage. Failure of the uterus to contract sufficiently after delivery and to arrest bleeding from vessels of the placental implantation site. So, to test your memory, the mechanism of placental separation can either be your Duncan or your Schultz mechanism. So for the Duncan, the blood from the implantation site may escape into the vagina immediately, while the Schultz sites, the blood remains concealed behind the placenta and the membranes until the placenta is delivered. Okay, and again, recall the 4 signs of your placental separation. With bleeding during the third stage, the uterus should be massaged if it is not contracted firmly. If significant bleeding persists after delivery of the infant, and while the placenta remains partially or totally attached, then manual placental removal is indicated. However, adequate analgesia is mandatory. If uterine atony happens after placental delivery, you may give a vigorous fundal massage, 20 units of oxytocin in 1 liter of your crystalloid solution will often be elective given intravenously at 10 ml per minute for a dose of 200 milli-IU per minute. Oxytocin should never be given as an undiluted bolus because serious hypotension or cardiac arrhythmias may develop. You could give it intramuscular or as said a while ago, you have to incorporate it in a crystalline solution, but never give it direct direct IV bolus. And then, ice pack on the uterine fundus. So what are the risk factors of your uterine anatomy? High parity, over-distended uterus, that is macrosomic or large fetus, multiple pregnancy, or hydramnios. And your labor abnormalities if the patient encountered hyper or hypotonic labor. And labor induction or augmentation with either prostaglandins, or if you given a oxytocin in a prolonged period of time, and if the patient has a prior postpartum hemorrhage history. How would you evaluate for your uterine anatomy? Careful inspection is done to exclude birth canal laceration. Inspection of the placenta after delivery should be routine because bleeding can be caused by retained placental fragments. Note for possible retention of a succentorate lobe that was retained inside the uterus. How would you manage if you encountered uterine atony? You have to administer your uterotonic agents, and the most common is your oxytocin that is infused intravenously or given intramuscularly after placental delivery, or your metarergonomine or your metargine. However, you take note of the precaution because it is not being given for patients with hypertension and bronchial asthma. Carboprost are the prostaglandin F2, dinoproston, your sulproston, or your misoprostol, or also known as your cytotec. However, misoprostol is prohibited in the Philippines. So if the bleeding is still unresponsive to your uterotonic agents, begin by manual uterine compression. That is, the posterior uterine wall is massaged by one hand on the abdomen, while the other hand is made into a fist and placed into the vagina to knead the anterior uterine wall through the anterior vaginal wall. Immediately mobilize the emergent care obstetrical team to the delivery room and call for the blood or packed red cells. Meaning to say, you have to ask for help to the people inside the delivery room and request urgent help from your anesthesia team. Secure at least 2 large bore intravenous catheters so that the crystalloid with oxytocin is continued simultaneously with blood products. Insert an indwelling Foley catheter for continuous uterine output monitoring. Begin your volume resuscitation with rapid intravenous infusion of crystalloids. With sedation, analgesia or anesthesia established, and now with optimal exposure, manual explore the uterine cavity for retained placental fragments or for uterine abnormalities, including lacerations or rupture. Thoroughly inspect the cervix and the vagina again for lacerations that may have escaped attention. If the woman is still unstable, or if there is persistent hemorrhage, then blood transfusion should be given. Other measures may include your uterine packing, your balloon tamponade, uterine compression sutures, your Billinge methods, your pelvic vessel ligation, your angiographic embolization, and the last resort is your hysterectomy. So what other cause of your obstetrical hemorrhage aside from your uterine atony is your uterine inversion, or also known as your purporal inversion of the uterus. The risk factors includes alone or in combination is the fundal placental implantation, delayed onset or inadequate uterine contractility after delivery of the placenta, cord traction applied before placental separation, and abnormally adherent presentation such as your placenta accreta. So again, go back to the active management of your third stage of your labor. So the picture in here is a example of a uterine inversion associated with the fundal placenta accreta during a home delivery. So for the management of your uterine inversion, once any degree of uterine inversion is recognized, several steps must be implemented urgently and simultaneously. Again, you ask for help, including your obstetrical and anesthesia personnel. The blood is brought to the delivery in case it may be needed. The woman is evaluated for emergency general anesthesia, and a large bore intravenous infusion systems are secured to begin rapid crystalloid infusion to treat hypovolemia while waiting for the arrival of your blood transfusion. If the inverted uterus has not contracted, and if the placenta is already separated, the uterus may be replaced by pushing up on the inverted fundus with the palm of the hands and fingers in the direction of the long axis of the vagina. If the placenta is still attached, it is not removed until the infusion systems are operational and a uterine relaxant drug is being administered. After removing the placenta, steady pressure with the fist, palm, or finger is applied to the inverted fundus in an attempt to push it up into and through the dilated cervix. Once the uterus is restored to its normal configuration, tocolysis is stopped. Oxytocin is then infused and other uterotonics may be given as described for atony. The operator maintains the fundus in its normal anatomical position while applying by manual compression to control future hemorrhage until the uterus is well contracted. The operator continues to monitor the uterus transvaginally for evidence of subsequent inversion. So for the surgical intervention, you can do your Huntington procedure or your Holton incision. So we have done with the uterine anatomy, your uterine inversion. Next is your injury to the birth canal or your lacerations. Vulvovaginal lacerations, usually there is small superficial tears of the anterior vaginal wall with little to no bleeding which do not require repair. Minor superficial perineal and vaginal lacerations occasionally require sutures for hemostasis. Extensive vaginal or cervical tears should prompt a careful search for evidence of retroperitoneal hemorrhage or peritoneal perforation or hemorrhage. So especially if you make use of the assisted vaginal delivery, making use of your forceps or your vacuum. You suspect if there is a profuse vaginal bleeding, laceration from instrumentation. In general, cervical lacerations of 1 and even 2 centimeters are not repaired unless they are bleeding. Such tears heal rapidly and are thought to be of non-significance. Deep cervical tears usually require surgical repair using either interrupted or continuous interlocking suture. So for the picture, this is the repair of your cervical laceration with appropriate surgical exposure. Continuous observable sutures are placed beginning at the upper angle of the laceration. So the laceration is in here. In the 3 o'clock and 9 o'clock position. Next is your purporating hematoma. So in the picture, the left-sided anterior perineal triangle hematoma is associated with vaginal lacerations following spontaneous delivery in a woman with mid-consumptive coagulopathy from acute fatty liver of pregnancy. So purpura hematoma, this is most often associated with laceration, your episiotomy, or an operative delivery. Occasionally, they are associated with underlying coagulopathy. So if there is a problem in the blood clotting factors. Faulty clotting may be acquired, such as with consumptive coagulopathy from placenta abruptio or fatty liver failure, or may stem from congenital bleeding disorders such as your von Willebrand's disease. Vulvar hematoma may involve the vestibular bulb or branches of your pudendal artery, including your inferior rectal, your perineal, and your clitoral arteries. Paravaginal hematomas may involve the descending branch of the uterine artery. So vulvovaginal hematomas may develop rapidly and frequently cause excruciating pain or severe perineal pain. There is a tense, fluctuant, and tender swelling on vulvovaginal area. Smaller vulvar hematomas may be treated expectantly. If pain is severe or the hematoma continues to enlarge, then surgical exploration is preferable. So we have the primary and secondary uterine rupture. So the primary occurring in a previously intact or unscarred uterus. For the secondary, it is associated with a pre-existing myometrial incision, injury, or anomaly. So please refer to your book. What are the examples of your primary and your secondary uterine rupture? So uterine rupture can either be classified as complete or incomplete. Complete when all the layers of the uterine walls are separated, that is from the serosa, myometrium, and endometrium. For the incomplete, the uterine muscle is separated but the visceral peritoneum is intact, also commonly referred to as uterine dehiscence. The most common sign of uterine rupture is a non-reassuring fetal heart rate pattern with variable heart rate deceleration that may evolve into late deceleration and bradycardia. Can also present as loss of fetal station and cessation of uterine contractions. So what are the predisposing factors and causes of your uterine rupture? First is your prior cesarean incision. So we have two cesarean incisions, that is your classical and your low transverse cesarean section. Comparing the two, classical cesarean section has an increased risk of uterine rupture. That is why patients with a history of classical cesarean section, automatically we schedule the patient for repeat classical cesarean section or cesarean section compared with your low transverse cesarean section. Other previous operations or manipulations that traumatize the myometrium, such as your uterine curettage or perforation, endometrial ablation, myomectomy, or hysteroscopy, and excessive uterine stimulation, or that is the use of your oxytocin in a longer period of time. So fetal condition depends on the degree to which the placental implantation remains intact, although this can be changed within minutes. With rupture, the only chance of fetal survival is afforded by immediate delivery, most often by exploratory laparotomy. With complete rupture, hysterectomy may be required. In selected cases, however, suture repair with uterine preservation may be performed. Fetal condition depends on the degree to which the placental implantation remains intact, although this can change with minutes. With rupture, the only chance of fetal survival is afforded by, I discussed it a while ago, immediate delivery. Next, obstetrical hemorrhage is your abruptio placenta. Abruptio placenta is the separation of the placenta either partially or totally from its implantation site before delivery. Placental abruptio is initiated by hemorrhage into the decidua basalis, leading to the deciduous splits, leaving a thin layer adherent to the myometrium. Abruptio begins with rupture of a decidual spiral artery to cause a retroplacental hematoma and can expand to disrupt more vessels and extend placental separation. So we have the chronic abruptio and the traumatic abruptio. Chronic abruptio, the chronic placental separation begins early in pregnancy. In some cases of chronic abruptio, subsequent oligohydramnios develops, known as the chronic abruptio oligohydramnios sequence. For the traumatic abruptio, that is secondary to external trauma, usually from motor vehicle accidents or aggravated assault, that can cause your placental separation. So what are the risk factors of your abruptio placenta? The age, parity, hypertension, premature rupture of your membranes, polyhydramnios, uterine myoma, cigarette smoking or cocaine use, and your lupus anticoagulant and thrombophilias. Abruptio placenta presents a sudden onset of abdominal pain, with vaginal bleeding and uterine tenderness. This is complicated by massive and sometimes torrential hemorrhage leading to hypovolemic shock. One of the most common cause of defibrillation syndrome, which is currently referred to as consumptive coagulopathy or TIC. Consumptive coagulopathy is more likely with concealed abruptio because intrauterine pressure is higher, thus forcing more thromboplastin into the large vein draining the implantation site. This can cause cobilious uterus, a widespread extravasation of blood into the uterine musculature and beneath the serosa, or known as the uteroplacental apoplexy. This is an example of a cobilious uterus. This can cause also a pituitary failure, or known as your Sheehan syndrome, a failure of lactation, amenorrhea, breast atrophy, loss of pubic or axillary hair, hypothyroidism, and adrenal cortical insufficiency. With a living viable size fetus and with vaginal delivery is imminent, emergency cesarean delivery is done. If the fetus has died, or if it is not considered mature enough to live outside the uterus, then vaginal delivery is preferable. So the next is your placenta previa. The placenta goes before the fetus in the birth canal. So we have the different types. You have the total, partial, low-lying, and the marginal. For the total placenta previa, the placenta is totally covering the internal os. So this one. Partial, meaning partially covering the internal os. And for the low-lying placenta, the implantation in the lower uterine segment, such as the placental edge, does not reach the internal os and remains outside a 2 cm wide perimeter around the os. So the magic number here is the 2 centimeters. For the marginal previa, the placenta was at the edge of the internal os but did not overlie it. For the risk factors of your placenta previa, we have your advanced maternal age, your prior cesarean delivery, multiparity, and cigarette smoking. Bleeding from a previa usually begins without warning and without pain. So this is the painless vaginal bleeding, or a contractions in a woman who has an uneventful prenatal course. Performing internal or digital examination is contraindicated because it can cause torrential hemorrhage. Ultrasound is used to localize the location of the placenta. If the fetus is preterm and there is no persistent active bleeding, management favors close observation in the obstetrical unit. For women who are near term and who are not bleeding, plans are made for scheduled cesarean delivery. For women whose placenta previa is implanted anteriorly at the site of prior uterine incision, there is an increased likelihood associated with placenta accreta syndrome and need for hysterectomy. So the last cause of your obstetric hemorrhage, your placenta accreta syndrome. Any placental implantation with abnormally firm adherent to myometrium because of placenta or total absence of the decidua basalis and imperfect development of your fibrinoid or your Nitabux layer. So we have the different types also of your placenta accreta. You have your the placenta accreta, placenta accreta, placenta percreta. So placenta accreta, the villi are attached to the myometrium. So accreta. For placenta increta naman, invade the myometrium. There is an invasion. Accreta attachment to the myometrium. Increta invasion. The myometrium invade. Percreta penetration. penetration. So, penetrate through the myometrium and to or through the serosa. So, again, akrita attachment, inkrita invasion, P, perkrita penetration through the myometrium. So, total placenta akrita, abnormal adherence of all lobules. Focal placenta akrita, if all part of a single lobule is abnormally attached. The two most important risk factors are associated with previa, a prior cesarean delivery, and more likely a combination of two. In case of first and second trimester akrita syndrome, there is usually hemorrhage that is the consequence of coexisting placenta previa. In some women who do not have an associated previa, akrita may not be identified until third stage labor when an adherent placenta is encountered. Fetus is delivered via cesarean section with subsequent hysterectomy. However, some of these abnormal placentations, especially if partial, may be amenable to placenta delivery with hemostatic suture placements. Okay, so that is the end of the postpartum hemorrhage. Are there any questions with regards to the postpartum obstetrical hemorrhage? It is just in your book. Any questions for the obstetrical hemorrhage?
No questions po.
Are you sure? So you're ready na for the exam, ha? When is your exam pala?
Doc, check ko po yung schedule.
Okay, sige. If there are no questions, I know you have a lecture, and again, galing a lecture at 10 a.m. So if there are no other questions, can we call it a day?
Yes po, Doc.
Okay, document na lang attendance, please. Elijah, did you get the attendance a while ago? Ang unang topic natin.
Doc, yung mga ward leaders po nagpo-collect ng attendance and i-report po nila yung mga absentees sa akin.
Okay. Okay, so get the attendance na.
Doc, I think okay na.
Okay na?
Yes po.
Okay, thank you. Keep
Thank you,
safe, everyone. Naku, hirap magkasakit. Okay, bye-bye. Thank you.